All right, today we're going to dissect two really critical forms of kidney disease, specifically glomerulonephritis. Now, what's fascinating is that both are kicked off by an infection, but depending on who gets it, the patient, they look like two completely different diseases. We're going to contrast the classic childhood version, post-streptococcal glomerulonephritis, which usually gets better on its own, with the adult form, infection-related glomerulonephritis, which is a much tougher customer. It's truly a tale of two very different diseases.
So here's our game plan. First, we'll set the stage and talk about where nephritic syndrome fits into the big picture of glomerular diseases. Then we'll introduce our two main players, PSGN and IRGN, and we'll spend some real time on what makes each one unique. After that, we'll dive into the pathology, what we see under the microscope, because that's where the differences really pop. And we'll wrap up by comparing their outcomes to really hammer home the key distinctions.
Okay, so in our past discussions, we've spent a lot of time on podocytopathies, right? Things like minimal change disease, where the podocyte cell is the main problem. Well, today we're shifting gears to the fourth major way glomerular disease can show up, acute nephritic syndrome. And this isn't a podocyte problem. No, this is all about a full-blown inflammatory attack on the glomerulus. And our poster child for this is going to be infection-related glomerulonephritis.
Now here is the absolute central point of this whole discussion. I really want you to get this. Even though they both start with an infection, childhood post-strep GN and the adult infection-related GN are fundamentally different diseases. They are not just different aged versions of the same thing. So let's start breaking down exactly why that is.
This slide really lays it all out, the stark contrast. Over on the left, you've got childhood PSGN. The host, a healthy kid with a normal immune system. The bug, a very specific type of group A strep. And critically, there's a delay, an incubation period, between the sore throat or skin infection and the kidney problems. It presents as a classic acute nephritic syndrome, and the prognosis is fantastic. Pretty much zero risk of long-term kidney disease. Now look to the right. Adult IRGN is a whole different beast. The host is usually an adult with a weakened immune system, often someone with diabetes. The bug is often MRSA. There's no incubation period. The kidney failure happens right alongside the active infection. The presentation is severe, often a rapidly progressive GN that lands the patient on dialysis. And the prognosis? It's terrible.
So let's start our deep dive with a classic textbook case, childhood post-streptococcal glomerulonephritis. We're going to look at who gets it and the specific microbiology that drives this whole process.
So your classic patient is a little boy, usually between 2 and 7 years old. And what's really interesting is that PSGN is one of the very few glomerular diseases where we've actually found a genetic link, specifically with HLA-DR1 and HLA-DR4. Now, the culprit is group A strep, but not just any old strep. It has to be one of these specific nephritogenic strains. The ones that cause a sore throat are usually types 1, 2, 4, and 12. The ones that come from a skin infection, impetigo, are types 47, 49, 55, and 57. And for anyone studying for an exam, you'll definitely want to remember types 12 and 49. Those are the favorites.
Okay, this is a hugely important point. A key diagnostic feature of childhood PSGN is this latent period. The kidney problems don't happen during the infection. After a sore throat, you have to wait about 7 to 10 days before the kidney issues show up. If it's from a skin infection, that delay is even longer, more like 2 to 4 weeks. This time gap is absolutely critical for making the diagnosis.
So what's actually causing the damage at a molecular level? Well, it really boils down to two main troublemakers, two specific antigens from the strep bacteria. The first one is called NAPR, which stands for nephritis-associated plasminogenic receptor. The second is SPB, or streptococcal pyrogenic exotoxin B. These two molecules are the bad actors that kick off the whole immune-mediated mess inside the glomerulon.
All right, so a child with PSGN gets admitted to the hospital. What are our top 3 priorities? Number 1, without a doubt, is getting that blood pressure under control. That NAPR antigen we just mentioned, it directly turns on the sodium channels in the kidney, something called ENaC. This makes the body hold on to a ton of salt and water, creating a state of massive volume overload. So we're checking blood pressure every hour and using meds like calcium channel blockers to prevent a hypertensive crisis, like a seizure or a condition called PRES. Second, we have to get that extra fluid off with high-dose diuretics to keep it out of the lungs. And third, we've got to watch that potassium like a hawk. The kidneys aren't working well, so potassium can build up, which is dangerous for the heart. That means frequent blood tests and keeping an eye on the ECG.
Now, beyond the immediate crisis, we're also watching the labs. In about 90% of these kids, the C3 level in their blood, a part of the complement system, will be low during the acute illness. but this is temporary. And there's a magic number to remember: 8 weeks. At the 8-week follow-up appointment, that C3 level needs to have returned completely to normal. This is a critical checkpoint.
And that 8-week C3 level is what helps us decide if we need to do a kidney biopsy, which I should stress we almost never do in kids with classic PSGN. There are really only 2 reasons to even consider it. First, if that C3 is still low after 8 weeks, we have to start thinking about a different diagnosis, like C3 glomerulopathy. And second, if the child gets this whole syndrome a second time. A core rule here is that classic PSGN does not happen twice. If it seems to, it's probably not PSGN and you need a biopsy. Otherwise, no biopsy needed.
Okay, let's pivot now and talk about our second disease, adult infection-related glomerulonephritis. And I want to be clear, this is a much more complicated, much more severe clinical problem. It's a real modern challenge for us in nephrology.
So the patient here couldn't be more different. We're talking about an adult with a compromised immune system, very often a man with diabetes who has an infection somewhere, like a cellulitis on his foot. The bug is usually MRSA, and remember that critical incubation period we talked about? Forget it. It's gone. The kidney failure is happening at the same time as the active infection. The presentation is typically really severe, what we call a rapidly progressive glomerulonephritis, often requiring dialysis right away. And to make it trickier, the C3 level is only low in about 60% of cases, so it's not as reliable a marker as it is in kids.
So how can we be so sure these are 2 different diseases? Well, the definitive proof lies in the pathology. When you get a piece of the kidney tissue and look at it under the microscope, the story becomes crystal clear. The differences are undeniable.
Okay, so on a standard light microscope, childhood PSGN is just screaming inflammation. The classic description is a mouthful: exudative neutrophilic endocapillary proliferation. What does that mean? It means the glomeruli are packed, just stuffed full of inflammatory cells, mostly neutrophils. The capillaries are so swollen and clogged that nothing can get through to be filtered. It's what we call a diffuse proliferative glomerulonephritis.
Next, we look with immunofluorescence, which lights up immune deposits. In childhood PSGN, you see these big, chunky, granular deposits of IgG and C3 all along the capillary walls. It creates this very distinct, speckled appearance that we call the starry sky pattern. It's actually quite beautiful in a pathological sort of way.
And finally, we bring out the big guns, the electron microscope. This gives us the smoking gun for PSGN. You see these huge, dome-shaped dark deposits on the outside of the glomerular basement membrane in what we call the subepithelial space. These are the famous subepithelial humps, and seeing them is definitive for the diagnosis.
Now contrast all of that with what we see in adult IRGN. The immunofluorescence is completely different. First of all, it's not usually IgG dominant, it's often IgA dominant. And the pattern isn't a starry sky. Instead, the deposits are more smeared along the capillary loops, kind of like a rope or a garland. It's called the garland pattern. It's a totally different immunologic signature.
You know, this table is super helpful because in glomerular disease, location is everything. Where the immune deposits end up tells you so much. So you can see PSGN has subepithelial deposits, just like membranous nephropathy. But that's totally different from IgA nephropathy, where the deposits are stuck in the mesangium. And that's different from MPGN type 1, where they're subendothelial, or C3 glomerulopathy, where they're right inside the membrane itself. So knowing exactly where those humps are is key to the whole diagnosis.
All right, let's pull all of this together. We're going to wrap up by summarizing the core clinical pictures and really reinforcing why these 2 infection-related diseases have such dramatically different outcomes. It is so important to keep the nephritic and nephrotic syndromes straight in your head. They are not the same thing. On the left, PSGN is your textbook example of nephritic syndrome. It's an abrupt onset. You have that overfill edema from too much volume, high blood pressure, and a very active urine with blood and red blood cell casts. And all of this is happening with a normal albumin level in the blood. Now compare that to nephrotic syndrome like we see in minimal change disease. That's a slow, insidious onset, underfill edema because of low protein, normal blood pressure, and a urine that's basically just dumping tons of protein, which is why the serum albumin is so low. They are true pathophysiological opposites.
So, I want to leave you with a final thought-provoking question. We've shown that childhood PSGN and adult IRGN are different in every single way that matters: the patient, the bug, the timing, the clinical picture, the pathology, and most importantly, the prognosis.
So, given these massive, consistent differences, does it even make sense anymore to group them under this one big umbrella of infection-related glomerulonephritis? Or have we learned enough now that our language should catch up with the science and we should start classifying them as two completely separate diseases? It's something to think about.